this is Dr. Herrick. He's a diplomat of the American Board of Family Practice. He's on the medical staff of Olathe Medical Center with obstetric privileges. He's a member of the American Academy of Family Physicians, Catholic Medical Association, Christian Medical Association, and Kansas Academy of Family Physicians. He has served as a clinical preceptor for KCUMB, University of Illinois, Kansas City, and KCUMB. Dr. Herrick is also a clinical instructor for natural family planning lectures. He earned his MD with honors in anesthesia, obstetrics and gynecology, and psychiatry. He also earned his PhD in biomedical engineering from the University of Iowa. He has published work on the analyses guide for patients with symptoms of acute respiratory illness. Please join me in welcoming Dr. Herrick.
Thank you. John Russell proposed to me a title of his talk, Counseling Patients on Birth Control and Pregnancy Choices. These particular choices certainly impact life, but there's even more that can profoundly affect what one's life becomes. Sometimes a patient request can come as a shock, as I'm sure does the situation that leads to the request. How does a physician handle this? There are conventional principles for guiding patients to treatment decisions. It should be stated that these principles are more clearly established for procedures, i.e. surgery, for example, than they are for medications. Informed consent must first provide information, and recognized standards for informed consent require that it provide the nature and the purpose of treatment, risk and consequences of the treatment, and alternate course of the treatment, including none, which is sometimes something I think we don't think about talking to patients about. The consent part of informed consent requires that there be no ultimatums, that a patient is not told, well, you have to do this, or else. It cannot be undue duress. No one can be forced to undergo treatment against their will. Physicians may tell patients that under similar circumstances they themselves would choose or implied not choose similar treatment. The number one source of liability is failure to explain relevant risk of the procedure or treatment. From a practical standpoint, when one is talking to patients about what they're going to do or what the physician advised doing, it can be a practical challenge to sort out how much detail to give a patient. Typical, or I should say, general guidelines would state that the nature of the condition which the patient has and the nature of the risk of the untreated condition are important to disclose. However, something that may not be immediately intuitive is that common knowledge need not be disclosed. Everybody knows, for example, that the birth control pill prevents pregnancy. I think we probably don't need to spend time, particularly in a limited time that's allowed at the patient encounters, to discuss things like that. The standard in a lot of states for informed consent is to tell the patient what a reasonable practitioner would tell the patient. This can vary state by state. I'm not an attorney. I'm not certain, for example, what Missouri law would say if they are a reasonable practitioner or a reasonable patient state. The reasonable patient criteria is that it takes it from the other side, where you should know what a reasonable person on the street would want to know. I think one problem interpreting that is it can be quite variable, depending on culture, educational background. Something that will become, I think, quite relevant for the people in this room as they progress in their medical education is when you get to residency and someone asks you or tells you to do something, and you have moral difficulty with that. What are you going to do? And I think one principle is, and one expectation that should not be held out there for residents is that they do not have to get consent for private patients. I mean, they do for clinic patients, for unassigned patients, but it's probably not good medical legal practice for an attending to ask a resident to consent to a procedure that's really the attending's own patient. I first wanted to start with discussing conventional approaches to informed consent, legalities involved. It's quite important that pro-life people, first of all, not violate the law, not get themselves in trouble for doing things that are really just not good practice. I mean, sometimes when there's no choice and there's obviously immoral law, and complying with that would be wrong, you can't do that. But I think, first of all, we need to be good physicians. And I found in my own practice that if you do your best, if you really go the extra mile to try to be personable, to try to just practice good medicine, people will come to you. And I think you don't have to worry so much about making a livelihood when sometimes you do not do what might be initially thought to be an impossible thing. So, first of all, yes, informed consent. We need to follow procedures for communicating to people. We should not be hiding from people things that we feel like, may not be conducive to the course of therapy we would prefer. So we first of all have to, be out front, be in the open. But second of all, and this is what is not recognized all the time by conventional medicine, by society at large, is the moral aspect. You can have all the right procedure in the world for telling a person this is your risk, this is your complications, but if that's all the further you go, it's kind of like a mechanistic approach. It's almost like a robot could do this, and so there is a right and a wrong. There's a moral structure to life and to decisions, particularly decisions in medicine a lot of the time. Edmund Pellegrino is an ethicist at Georgetown University. And these are quotes from an article in the Winter Quarterly. What is decided is more morally relevant than how it is decided. And a legal settlement for a moral conflict cannot replace the morally correct decision. No matter how mechanistically correct informed consent is, it still can lead to a procedure that's wrong. Why morality? I think if a provider is going to be out there wanting to try to promote the right decision, that they're going to have to be able to tell people, to be an apologist of sorts, for, well, why should you have any sort of moral values? Certainly there's a mindset out there that providers need to be moral neutral. They need to check in their ethics at the door, and whatever the patient says is what you do, and you just kind of guide them to help them clarify their values. And certainly every person has a right to expressing values. But if we are to talk about being pro-life, then we're going to have to become, even on a more basic level, more than just saying, well, life begins at conception, to say, why should we even be able to have that discussion in public? And one reason why morality is that informed consent itself is not a prima facie concept. It didn't come down from the sky onto a mountaintop and that's it. It's not the base from which we derive all other moral decisions. Informed consent is actually dependent on other concepts, a more fundamental concept of human nature. Informed part of informed consent derives from the part of human nature that we all have, is that we have reason, and so we can process information. The consent part of informed consent comes from the free will part of human nature, and we all can make choices. We have that power to do so, and so that's where the consent part of informed consent comes from. And we have a right to informed consent because reason and free will are what constitute humans in the image of God. Autonomy is an example. Autonomy is I've heard one ethicist sort of tongue-in-cheek say, there are, in the end, there are three things, and autonomy and beneficence are two of them. But autonomy, again, is not a prima facie concept. It's arbitrary unless it's grounded in something more fundamental. Why morality? Because Americans are still very religious. This year, the Pew Forum published its latest religious survey of the American public, and it made it to the papers. You may have seen it. Something that was not immediately evident is that 89% of Americans are either affiliated with a particular religious tradition or unaffiliated but still consider themselves religious. In this survey, only 2% of Americans were atheists. And certainly that is something they have the freedom to choose, and I would not interfere with that. But sometimes I think, based upon what we hear in the press, we get the impression it's something like 30%. So the fact that Americans are religious leads us to believe that they're going to look for some sort of moral judgment in important decisions of life. Why morality? Individual patient decisions don't always affect just the patient. No man is an island, and it can affect others. When there's pregnancy, it affects the other patient. Dr. Calhoun eloquently spoke of. At the end of life, there's the family there. And what the patient decides is certainly going to impact that family. In intimate behavior, there's the other partner. If someone has an STD, they have if they have herpes, they have a moral obligation, I think, to tell potential partners that they have that. Controlled substances, very common these days. Large number of people are taking them. There are issues of diversion of these substances to other people. The medicine cabinet at home. These days more teenagers abuse prescription-controlled drugs than illicit drugs. Driving, there's a fair number of people out there who are driving under the influence as bad as alcohol. And what the patient decides can also impact the physician. The physician is not a neutral moral agent. What the physician does for people affects who that physician becomes. So the patient cannot entirely substitute his or her informed consent for another's, even by proxy. When we make decisions for our children, we're certainly acting in their interests, but we have to have their interests in our account. We just can't make our own interests the basis of the decisions about our children. Examples of these kind of things come from John Brahaney, PhD in ethicist. He says, for example, say a frat boy comes to a physician requesting ketamine before homecoming. Or, in the 1850s, if there was an escaped slave and in the North, and the slave hunters capture this person, they come to a blacksmith and say, we'd like you to forge shackles so we can take them back to the South. These things are not morally neutral.